Dilip sir,
Hi, sir.
how are you?
Good, sir.
You're not in the OPD today?
Yeah, sir.
No, sir.
All
Today I
well?
finished my
All
OPD
well? All
earlier.
well? All
All
well?
well, sir. All well, sir. I'm doing the shoot. Yeah.
Fantastic. Great to see you.
Sir, we are live now.
Thank you very much. So, hi friends, this is Dr. Apoor Mehra, and I represent team E-Conceptual here. And first of all, thank you very much for all the trust that all of you have shown on us. It's been, believe me, it's been 6 years of we are in the sixth year of launching the platform, but this dream belongs to somewhere around 2017 when I went to my teachers requesting, let's go online and teach postgraduates. Being into teaching for the NEET PG and FMG segment, I always realized that a doctor principally orients itself to entrance exams. That's important, but what is more important is we are doctors. हम डॉक्टर बने क्यों थे, right? And the skills are going to be there with you forever, which is very, very important. So during MBBS, if you summarize, it's mainly about profs. And when you come to internship, it's about entrance. And by the time you're out of it, you are into a branch. And then if you take a branch which is not an end branch, you want to go for super specialty. But somewhere down the line, when you are in open, the patient does not look at your old history. They look at their history and they look at how you behave. And that's what conceptual was about. The senior teachers had mastered an art of clinical examination and history taking, that diagnosis. And somewhere there was always a complaint, आज वैसे बच्चे नहीं हैं, आज पढ़ाने वाले नहीं हैं. So I was looking for an answer. चलो आओ, हम आपको पढ़ाएंगे. चलो पढ़ने वाले बनो. Many a times, just one exam decides you go to some different college. And is it sealed? Is the fate sealed? Why not to have a platform which is level playing, which gets you all on the same level? Means अगर एक व्यक्ति एम्स में सिलेक्ट हो गया, एक व्यक्ति मैमसी में सिलेक्ट हो गया, या एक व्यक्ति एमएमसी चेन्नई में सिलेक्ट हो गया, या केईएम चला गया, क्या वो बेटर हो गया? Is it actually the truth? If I talk about my branch, right, the is the first time that all the journals of a particular branch have spoken about a man called as C.S. Ranawat, Chitranjan S. Ranawat. So Ranawat is one of the biggest orthopedician of the world, right? And we lost him this year. And from 1934 till 2025, 89 years of his life, right? He's built up orthopedics as a branch going abroad in US, and there's a place called as Center for Surgical Excellence which he has built. Even in US, that's an Indian. He doesn't belong to the top colleges, as they say. He's been educated from Indore. But does that mean that he's not the best? He's absolutely the best in the world. But what was required was working hard in the branch you get. You take MBBS, you have 19 subjects. You give entrance, you have 19 subjects. But when you take a branch, you are married to it. There is no escaping. And here comes the experience being transformed. So we all thought as teachers for next 3 years what to make and how to make it. And the tagline was the aim is not to live forever, but is to create something that can. Me being the aggressive self, I said, I wrote a line which was changed by my teachers. I wrote a line that, right, to stop me, you will have to kill me, but even then you cannot stop what I have created. That was the line I thought of, but obviously the teachers are experienced, so they came out with a very different perception. They said, why not to give a tagline by Professor S.M. Tuli sir, the learning never ends. Why not to just make it very simple? And the moment he said this, it clicked with everybody. We were at his home. He gave this line. This line was given to us on 13th of December 2019. 20th December 2019, he was at the studio recording the first video. And after that, trust me, Zainab, Rana ma'am, Janvi, Dilip sir, Anand, every Monday and every Friday, sir would come at the age of 89 to record here at the studios. He taught us with the hands, हाथ पकड़ के सिखाया उन्होंने कैसे. He would climb up, ma'am, अगर आप लोगों ने देखा हो, he would climb up 2 floors, 3 floors of the clinic and we would take up the lifts, and he was so fit at that age. And the line he would always say is, as long as I'm fit and healthy, I'm going to be with you. And trust me, I replied, Ki, sir, you have a bigger responsibility to improve the quality of postgraduates of the country, improve the clinicians of the country, pass on the right thing, that how to respect the seniors and juniors, the interaction between the doctors that we call as medical etiquettes, and finally passing on the medical ethics, how to be calm. He had built up the whole Banaras Hindu University, BHU, with his own hands. And one point on time, there was a situation then he had to quietly walk off without even telling anyone why he walked off. It's been 40 years he moved out of that place, but we never know why he walked off. But he taught us that if you focus on your patients, if you are honest towards your work, कोई आपको रोक नहीं सकता. And then he taught us that the most important thing is with the patients is patience. They are in pain, the world is in pain, and we are the healers. You know, when I was recording the first video with him, I wrote a mail to Mr. Harsha Bhogle, and I requested for a line from Mr. Harsha Bhogle that used to speak for the straight drive of Tendulkar, that with a touch of class and a stamp of authority. So I wrote a mail to him, and there was a match, and he was actually going to start the commentary for the same. And I thought that he would take some time to reply. I said, I am building a platform with all the senior doctors in the country, with all the legends in the country who are committed to their branch. Can I use this tagline on the website? And he immediately reverted back that absolutely yes, you can use this line. Within a flash, this came that you can use this line. Now, this is the thing about people. They understand, how it is. Then we had to launch a program, and we launched conceptual orthopedics as the first branch of e-conceptual on 2nd April, right, 2020, amidst COVID. Whether it came as a blessing or not, we don't know, but we chose 2nd April because India won the World Cup on 2nd April 2011, and all the important things we used to do on the same date, right? Conceptual orthopedics on day one, if you look at the numbers, became a hit. If you look at the subscription, became a hit. But what was more important was it was the first thing in the world of the kind. You are not known for what kind of things you make. You're known for how different you are from the world. And today, conceptual orthopedics as a branch is almost there in every phone in the world, being downloaded and being assessed in almost every country where you go. To the surprise, when teachers from London went to Hong Kong to take an exam, the students of Hong Kong who appeared for the exam were telling the teachers that we go through conceptual orthopedics for lecture so that we can predict what questions we will ask. That's how it went. There are steps as the organization builds up. I still remember when I spoke to Janvi when we were launching anesthesia, she said, "Sir, मैं दिल्ली आके 1 महीने रुक के काम करूंगी." And Janvi, I always used to tell you that the complete app which was launched was anesthesia because the recordings were all in studio. The content was carefully drafted and it was so well synchronized. She was here every day from morning till night, Zainab. Trust me, it was opposite of what you did, Zainab. So I'll explain what you did, but this is what, and she made sure, she said, sir, it is like my baby. Now she has a baby. At that time, she did not have. Now she has two baby. One is conceptual anesthesia and second is Vardhan. And also conceptual anesthesia is very close because this is what my closest friend Saurabh thought of making with you. So this is something which has been absolutely close. And trust me, when I walk every morning to my operation theater and there are DNB students and they see things from conceptual anesthesia, nothing can be so easy and so wonderful. That's what you have done, right? Subsequently, we came to a junction. Every app has a story to say. You know, I made something, you improved a version of it, Janvi, but then Zainab came and made it global. We all know that what Zainab does, right? She made it global. So basically, what I will say is, I got the name, you got the class, she got the publicity. That's what I can say. This is what I say. And then Zainab, because Zainab when launched, there was no lecture. It was just launched, you know, And then how beautifully she has been working, on it. And I think getting the team together with all the legends of the country, what you people have done. People had one thing on conceptual is all the senior teachers were trusting. Teachers were getting teachers. It was not difficult. You have seen Janvi has you got all the senior teachers. Dr. Rakesh Kumar is there with us now. Dr. Rakesh Garg is there. You yourself got your teachers, Janvi, right? Zainab could get the entire team made, right? Subsequently, then Dilip sir, you have a person, a Wanted movie. Have you heard of a movie called as Wanted? In which Salman Khan is there. He says that एक बार commitment करके तो मैं अपनी भी नहीं सुनता. So we got a lady called as Rana ma'am, came with gynae ops, and she actually built it so beautifully. We are always thankful, ma'am. The way you work, not everybody understand this, that to build a thing there has to be a lot of work at the back end, and there's so many things that you, Janvi, Zainab does for conceptual, so that every other branch now following is very easily set up on the benchmark. जानवी ने बुक्स का सेटअप ऐसा बनाया कि उसको कॉपी करना इजी है. जैनब ने उसको एक कदम और बनाया, and you're making further. And then we have got two things which are introduced in last 1 year. I always tell Zainab, till the time you don't penetrate South, nothing can become successful. And then came Dr. Dilip sir, who made conceptual very popular down south. I had conceptual orthopedics, one of the segment in Mangalore, but sir, you coming from there gave a good start to conceptual medicine. And aapki to popularity, your popularity is very different. You know, those who like you, they don't like you, they love you. So there is only one category. You know him, so you love him. There is no other category with you, sir. And then came, the man, life is beautiful. And that's what we launched in this August. This is beautiful. We also had in between conceptual surgery, which Amrit is handling. He is not on the screen because obviously I think Janvi and Amrit are on duties alternatively. And we also had conceptual psychiatry, which Praveen launched in between. So these are the branches which are there. Now I have introduced about them, right? Trust me that we have just started, or maybe we have just not even started. We have people who are absolutely committed. Janvi will tell you that anesthesia is the best branch and it gets you a lot of revenue. We are waiting for that to shoot up. That's what she'll do. I'll tell you, if you want to when you want to learn orthopedics, I've got 5 things for you. The first thing about orthopedics is it's a branch which has got surgical and medical conglomeration. The only other branch, according to me, which has got an equal balance is gynae ops. You can work as an OPD person and you can work as a surgical person. This is for anxiety of people who says that will I be a good surgeon or not? Trust me, I will tell you ABC of practice. A is availability. If you're available for your patient, you are the king. B is behavior. If your behavior towards your patient is kind, you're good. And the C is competency. You just need competency in less than 5% of cases. 95% medical science is simple. If you leave that 5% in first 5 years of your practice, you are going to be successful. First 5 years, don't touch. If you're choosing a surgical branch, remember it is important to know when not to operate. If you are clear about it, you are going to be good. So the first question, if you doubt and you still want to try for a surgical branch, gynae obs and ortho are good ones. The second thing, is ortho saturated? I will like to quote one of my closest friends, Goga Bhai here. स्कोप बंदे में नहीं, स्कोप ब्रांच में नहीं, स्कोप उस बंदे में होता है जो ठान लेता है कि मुझे उसमें नाम करना है. So that is what you have to understand. You have to become that banda, right? If you look at what these people on the screen have done, they have gone beyond their branch. हर इंसान बोलता है हर ब्रांच में एक सैचुरेशन है. ऑर्थोपेडिक्स में भी सैचुरेशन है बिकॉज ऑर्थोपेडिक्स के साथ एक प्रॉब्लम है, हर हर शहर में सारे अस्पतालों के मालिक वही हैं. So that's not the point here. The point here is if you are good, at the base, the pyramid is very broad. But if you keep on learning, as the line says, the learning never ends. Peak पे इतनी fight नहीं होती. So you have to escalate up each year. It is step by step. One of my friend, Dr. Shailesh Pai, in orthopedics, has written as a tagline, I want to climb up a mountain to see the top of the next mountain. So that's what you have to keep learning in orthopedics. So there is limited amount of competition, but if you stay in, you can kill that competition. Second thing. Third question asked to me about money. Surgical branches have a long learning curve. It's not ending anywhere. But with robotics coming up in the branches, there is going to be further escalation because the tech is coming with you. And the amount of money that you wish to earn will keep on growing, but then you have to work hard on it. Number fourth, sir, is it really very hectic? It depends upon you, right? There is no limit to the greed that you have. But if you know in life where to stop, it's good. I'll give you an example. There's a game called as less than seven, lucky seven, more than seven. So I went with my daughter to a place and I asked her to put 20 rupees on it. So she put her 20 rupees on more than seven. She won it the first time. She got 40. I told her, keep 20 in your pocket. Now put 20 again. She put it on less than 7. She again won. I told her, let's move. It's done. That's what you should learn because if you play further, you're gone. We all know we have done this in our melas. We don't win at the end. We keep on losing it after that. It's like same in life. You should know where to stop. And that's what you should learn from a lot of sports person. They retire at their peak. So you should know where to stop because if you don't know that, it's going to be confusion. This is extremely important that you should be sure. And the last question is orthopedics for the females? My co-guide, right, is a female. She ended up heading AIMS Rishikesh. I have a lot of students who are taking up as females who are taking up this branch. No problem at all. But you should understand one thing. If you're going abroad, कोई problem ही नहीं है. If I'm staying in India, majority of the people do group practice. So in group practice, you'll be part of a team joint replacement and pediatric orthopedicians, a lot of females are there. So this is what I want to tell you, right? Next thing, sir, क्या पढ़ना बहुत पड़ता है? Obviously not as much as you used to study in radiology or dermatology. But then if you get your basics correct, as I told, इतना पढ़ लो कि आपकी सर्जिकल काम में कोई मुश्किल ना आए. And I will tell you one general statement about all the clinical branches. In the first 10 years, you write 10 medicines for every disease. And after that, you write one medicine for all 10 diseases. That's what medical science is about. You have to understand and pick up quick. Trust me, one thing that you should remember, if you are into a clinical branch, my advice is, if you have a patient, before you start looking at the reports, examine your patient thoroughly and set a diagnosis in your brain. And number two, if you're looking at any radiological investigation, patient watches whether you see the images first or you read the report first. Because this is what, and that's what you have to practice. This you will acquire with time. And remember, you will learn from every senior. We will have dedicated session on 20th November at 8 p.m. where I will be getting all the orthopedicians who have built up conceptual along with senior people to talk. So I will see you there, right? I am passing on the baton to Zainab now. And Zainab, it's your responsibility that जानवी ढंग से बताए कि जो उसका अभी भी रील जो है वो ट्रेंडिंग है that how you can earn in anesthesia because trust me, I have seen anesthetists who earn more than surgeons. Trust me. I have seen general physicians doing far better than people who have done DMs. I have seen pediatricians right at home also who are doing excellent in spite of not doing their super specializations. And I have seen radiologists building up legacies, right? Which you should not compare because there's one on the screen, right? And we have got gynecologists who are practicing ethically and building up great things. And I'm very sure the guy who's here, Amrit, तुम आ गए ना तारीफ कराने. So this is the guy who's trying to orchestrate the entire thing of surgery now, and we are really thankful to Amrit. And ये सब वो मोती हैं और ये सब वो धागा भी हैं जो पूरी की पूरी सुंदर माला बना रहे हैं हर ब्रांच के अंदर. I always tell with people around like this, e-conceptual is only going to go up. All right. And I wish Ravi bhi hota, but he's traveling, so Ravi is not here. But I think Zaram and Ravi have got huge thing to handle. In my absence in Delhi, they take care of things, and that's what they have to do. जानवी जरूर समझाना सब कुछ, अमृत जरूर समझाना सब कुछ. Dilip sir, have a great session. Please explain about taking up general medicine and what if you don't do DM in future, because that's what people have asked. And same to you, Rana ma'am and Anand sir. Over to you, Zainab. Thank you very much.
Thank you, sir. I almost forgot I had to talk. It was like listening to a master class in life whenever you are talking, whether it's in, offline sessions or right now. I was just listening like a student and enjoying so much. So thank you so much. And I think on behalf of everybody on the screen, we all have to thank you for giving us this platform, and we have giant shoes to fill in with how orthopedics has done. So, always trying to emulate and learn from the best. So, thank you so much for that, sir. Now, getting straight to why you should take radiology or why you should not take radiology, I just have one slide to show you so that, I can just tell you what are the pros, what are the cons, what the residency looks like. So, I'll just share a slide and just show you. Um, I'll also discuss why I took radiology. So you can see the pros and cons. Like I'm pretty sure all of you take up, when you think of taking radiology, the biggest factor is always work-life balance. So that is a big pro, So this is, I think, perhaps the only branch where you can leave your work at work and that would be okay. No harm gets done in that. So work life balance is definitely a big bonus for radiology, which is there. But do not look for work life balance for the first 6 years. In your training period, do not think of work life balance. Ki 9 baje aayenge, 5 baje jayenge, not gonna happen, right? But eventually, once you've trained, you've finished your residency, you've finished your senior residency fellowship, after that, you do get the freedom to dictate your work hours, much like many other branches. But here, you get more freedom. Very similar to anesthesia, this is, I think, another branch where freelancing is an option, right? You can do multiple things here. Yeah, so you can do multiple things, you can work in multiple hospitals, you can, have your own center, work as a consultant in a hospital, you can do that. So that's one another advantage. Why I took up radio personally is I get bored very easily doing the same thing. So, radio works very well for me. Everything that you might have seen in Dr. House MD growing up, I think radiologist is the closest that gets to it. You have to run a lot of algorithms through different patterns. You'll see a lot of images, you run a lot of patterns, in your head, a lot of algorithms, and that's something which intrigues me the most, of how you get to the diagnosis of a patient, incorporating multiple things. Also, you get to see wide spectrum of cases, right? Multiple modalities. You get rotated every 1 month to 2 months in different hospitals, right? So 1 to 2 months you shift. You are in mammography, you get ultrasound, CT, MRs, intervention, which is non-vascular, vascular. So there's a lot that you can choose from, and then pick up a niche and specialize in it. That I feel is one of the biggest strength, is the flexibility that it offers in terms of the options. So that is something which is very interesting. One moment you're looking at an HRCT chest, you look at a brain tumor, you look at a peripheral Doppler, you look at a trauma case. So you get to see a lot of stuff. That also brings to the con, that you have to read up a lot. It's a very academic branch. So if you like academics, I was very strongly inclined to academics, so this is what resonated with me. But if you don't like studying, you're like, no, I don't want to study, I want to practice more, radio is not for you. So this is definitely where you have to get to study each and every branch, and you'll have to spend a lot of time learning it. So that's what we try to do in conceptual radiology as well. Different topics, we get into the diagnostic algorithm and how to approach those cases. Something which is a strength and a weakness is that you are not a patient's doctor, you are probably a doctor's doctor. That's how you can best describe a radiologist. You do not get a lot of patient interaction. fraction, which I've written in both pro and con, depending on how you look at this. So it could be, a plus point for somebody who doesn't want a lot of patient exposure. But if you are somebody who likes to talk to patients, who likes to be in contact, don't take radiology because you will regret it. This is where most of your work hour is going to be spent looking at a computer screen with you and your brain, and that's it. So that is where it does get isolating. Nobody comes and tells you thank you. So that is what it is. There is no gratitude. Or there is no violence, so there's both. So that's what you have to understand, that it lacks both of these things. So that's what I can tell you about radio. Money, I think all of us will eventually talk about, and you will ask how much is the pay. Government hospital, everybody gets the same pay. The advantage, or the notion that people think radiologists earn a lot of money probably stems from the fact that you start earning more money initially, right? So as soon as you finish your training, MD, 3 years, 6 years after SRship, you do get a higher pay than a few of your counterparts, but that plateaus. So the doubt with the money is that it will plateau very early, and after that there is no increase if you are working in a hospital. If you open your own center, then for any branch, sky is the limit. It depends on you how much you can make. Opening a center, radiology center, not very easy, especially if you are in a metro city. Opening your own ultrasound center also will be very, very difficult. But if you are in a smaller city, then you can start with ultrasound center and expand. So that has the maximum potential for making money if you are in an independent setup, or you have your allies and you're working with that. Hospital, the pay plateaus, so that is what it is. So that's what it is. I think one of the major doubts which students have is AI, artificial intelligence, which I think is looming large on every branch. I saw a recent viral post about AIMS having triage. So what AIMS is doing now is, because AI has a very high negative predictive value in looking at chest x-rays, let's say I have 100 x-rays in a day. I run it through AI. What AI will do is triage it for me. Because it has high NPV, it will screen the normal ones, and that is passed off as the final report with thing disclaimer that this is AI read. All right. So the radiologists are not reading that, but whatever AI has reported as question mark finding, the radiologists are looking at it. So is this replacing radiologists? Maybe. It is replacing, I would be delusional if I say it will have no impact. It will have impact. But the thing is, now you are focusing, rather than on triaging and going through normal radiographs, you are focusing your attention and your brain into what you have skilled, what you are skilled for, which is essentially looking at abnormalities and diagnosing it. So it does replace unskilled labor, but it brings and complements your skill. That's how I would describe the role of AI. So apart from that, what AI is doing now, what we are using AI for is a lot of texture analysis, a lot of radiomics, where you look at scans, you analyze texture of liver masses, lung masses, you get to detect the genetic mutation there, right? So that's what it is being used in. So a lot of interesting stuff. It's radiologists who are working with AI, right? And finding out more and more things and patterns which probably human brain and human eye cannot assess, which using, AI segmentation we can assess. So that is something which is very, very interesting. So now for the next 5 years, if you are taking up radio right now, this is the most interesting time to actually use AI in clinical practice and take radiology further. That's all the research that's going on right now is, application of AI. So that is what is my take on it. So, I read a very nice statement that AI will not replace radiologists, but radiologists who use AI will replace those who do not use AI. So that's what the take, has to be as far as AI is concerned. Another concern which residents have is radiation exposure. So here I talk about the most interesting branch of radio, which is intervention. If you have a surgical bend of mind, you want to do more interventions, vascular intervention, It's very, very interesting. It's, extremely, lucrative in terms of how it will grow in the next 5 to 10 years. So, vascular and non vascular, there are two interventions. For non vascular interventions, you don't need to do a DM after 3 years or, 3 years of SRship. You are good to do any non vascular intervention. That's a very well balanced life. Vascular intervention, you would want to do a DM, or you can do fellowships and further specialize. So that's where the trajectory and the learning curve is very slow. It is almost like a surgeon. So it will take a lot of learning years from your end, at least 3 to 5 years before you can start practicing independently. But there is a risk of radiation, but you don't have to be scared, right? We have a lot of tools for radiation protection. That is not something that you should be thinking of right now and would prevent you from taking up, radiology, because you will use a lot of things that will protect you from radiation. So that is not something that you should be worried about. So IR, very, very interesting. So this is what is my take. So those are some concerns which you have. In IR, what does IR entail is another question. So there are many things. A lot of it is dealing with um, embolizations in terms of aneurysms. So, neurointervention deals with aneurysms, it deals with stroke management. Then body intervention, where we deal with HCC, we do TACE, right? In trauma abdomen, you'll do embolization. So, body intervention is something which is definitely the forte of just IR. Neuro, a lot of it gets, enroached by neurosurgeons. Cardio, almost everything is done by cardiologists. We don't do any cardio interventions. So, neuro intervention has an overlap, but body intervention is exclusively body and peripheral extremities exclusively done by IR. So there is a lot of scope in that. So particularly in cancer treatments, we are now doing a lot of chemoembolizations. So that's something which is very, very interesting. So yeah, that is what it is. So I think I've covered most of the doubts. If there are any, I will take them up. But I want to now pass it on to Janvi ma'am for selling anesthesia as she will, and will make sure the cutoffs rise again in anesthesia. So yeah, please ma'am, take over.
All the radiologists who are scared that AI will take over, come take anesthesia. AI will never take over anesthesia. You have to be present in the OT. A machine or a computer cannot manage the case. All right. Thank you so much, Dr. Zainab. And I would, of course, like to start off with this statement that everyone who has completed a NEET PG exam and is looking for, counseling says that I'm not getting this branch or I'm not getting that branch. So people will say, I'm not getting radiology, I'm not getting dermatology, I'm not getting OBGYN, I'm not getting medicine. But there is no one who will say, I'm not getting anesthesia. Okay. Why? Because you have the maximum number of seats in the entire country. And this is not telling you that no one wants anesthesia. This is telling you that the requirement for anesthetist is so huge that despite having so many seats, we are not able to fill it in. Okay. Now, my second point over here, straight point, is anesthesia is like an arranged marriage. You may or may not like the girl. You don't know much about her, and you're wondering that what are going to be her skills. Are we going to be compatible? So. All the boys like to have a love marriage, but once they get into an arranged marriage, they realize that Ariva, she's a very good cook. Ariva, she's able to manage the child. She's able to manage home. She has a great profession, and she's complementing me very well. So this is what happens after you finish 6 months in anesthesia. You realize that this branch has everything that you wanted. Let's talk about each thing. First thing, work life balance. Now, I can say something great about work life balance from my own personal experience in the last 1.5 years. I could practice anesthesia while I was pregnant. I could take decisions of what kind of cases I wanted to do, whether I wanted to freelance. So, this is great for someone who wants to work 2 hours a day or who wants to work 12 hours a day. It's absolutely up to you. Work life balance is something that is a personal thing. Someone is a workaholic, wants to earn more money, you can go ahead, do more cases. Someone wants to do just 1 or 2 cases in the day and do something else, you can absolutely do that with anesthesia. So you are your boss in anesthesia. Okay. Second thing, you in many branches it will be like you're getting diploma seats, so you will say that, I'm not very happy with diploma OBGY or diploma surgery or diploma ENT because I'm not going to get much exposure. But you know what happens in case of anesthesia? Even if you're getting diploma anesthesia branch, there is so much work that diploma candidates get to do as much as MD or DNB candidates. And when you do secondary DNB after diploma, you are at the same level as an MD or DNB candidate. This does not happen in many branches, but in anesthesia, DA plus DNB is equal to MD or primary DNB. Okay. Third, very important thing, the minute you're out of your MD or DNB, of course, we do recommend that you should do your SR ship or you should do another fellowship or DM. But if you don't want to do any of this is the favorite question people ask. Ma'am, is this an end branch? You're tired? You want this to be an end branch after 3 years? Fine. You can just pick up your bag. Your maximum investment in this branch is going to be 10,000 rupees. You have to buy the basic things which nowadays are available in all the hospitals. Okay. So you don't even have to carry most of the things. And this is all. The only investment that you have to give is your time and your expertise. The next thing, which people say is a con, is that no one knows me as an anesthetist. The patient goes off to sleep, and then when he wakes up, he doesn't remember me. Okay, for all those who believe that anesthesia is a branch where patients don't know you, that means you are not performing pre anesthesia evaluation. In pre anesthesia evaluation, it's like having your own OPD. You're going to see the patient thoroughly, you're going to explain what is anesthesia. Many a times we even have to explain what is going to happen in the surgery because they don't get enough answers from the surgeon. So you will be given more. See, whichever doctor gives more time, the patients will talk to more to them. So it's up to you how much time you want to spend on the pre-anesthesia evaluation. And of course, after the surgery, post-op also, you are supposed to follow up with your patient and see whether they're doing well in the recovery room. If you're doing these two main thing, allaying the anxiety of the patient, allaying the fears of the patient, and also taking care of the pain of the patient perioperatively, the patient, trust me, is going to remember you over, not, I would not say over the surgeon, that would be saying too much, but the patient will remember you as much as the surgeon. I have had people specifically mention that this is the anesthetist I want for my surgery because last time I had a very good interaction with her. Okay. So it totally depends on what kind of person you are. Next thing, people ask about money. Ma'am, anesthesia has a ceiling effect, or we don't get paid much. There is a lot of competition. So, in money, I would say, like just Dr. Zainab said, come to three tiers. First thing is government hospital. In a government hospital, you get paid almost the same in all the branches because government hospital, the pay scale is as per the central government or the state government. So, it is almost the same for everyone depending on what level you are, assistant professor, professor. HOD. Then second thing is corporate practice. Yes, I would definitely agree that in corporate, anesthetists do get paid lesser as compared to surgeons or radiologists. But look at the good side of it. You are not getting the patients. The surgeon has to publicize himself and get the patients, and that is why he's getting more money. And trust me, it's not easy to get patients at all nowadays. Like you have to spend money in marketing, you have to spend money in publicity so that patients come to you. You don't have to do any of that. You have to just be available for the surgery and you know that you are going to earn out of it. Not as much as surgeon, but a decent amount to have a very good life. If you want to earn money, ma'am, I want to make money, I have a lot of aspirations, I want to do a world tour. Yes, go ahead, do freelancing in anesthesia. You can do many cases and earn a lot of money. And you can do cases in bigger hospitals where the pay scale is higher. So it in freelancing, as Dr. Zainab also said, sky is the limit. And the best thing is, if you want to freelance, you can do two things, not just anesthesia, but you can also do critical care. So in between cases, if you have time, you can go and take rounds of ICU. You can be the critical care physician. You can do interventions over there, like putting, simple things like the skills required are something that even an MBBS student would have. How to put a central line, how to put a difficult IV line, how to put Riles tube. For all of these things, they call the anesthetist because the anesthetist is A for anesthesia, A for available. All right. So as long as you are available, they will be paying you for each and every intervention that is done, as because you are the ICU physician and you are taking care of the ICU. In this branch competition, yes, of course, I would not lie. There are a lot of anesthetists. There is a lot of competition. But how do you get over competition? Competition is there in every branch. You have to have a niche of your own. You have to learn something that the other anesthetists don't know. So if you say someone 25 years senior is being called for cases, I'm not being called for case. Fine, go and learn ultrasound guided regional anesthesia. That is something that they will not know because ultrasound has come in the last 5 years. Then trust me that for doing cases under regional anesthesia, you will be the first person to be called, irrespective of your number of years of experience. And this applies to every branch. You have to learn something that the others don't know so that you are given preference over the rest. Other than that, yes, as I said, AI is cannot take over. AI will help us in the, like drug calculation, infusions, and stuff. But AI cannot take over anesthesia because imagine you are under general anesthesia. Would you want a computer to be giving commands on whether you will wake up or not, or in what time you are going to wake up? You will definitely want a human to be there to take care of any aberrations as well as even normal, just to be sure that you're going to wake up. So that human touch is always going to be there. And of course, if you do take up anesthesia, then we at Conceptual Anesthesia have the whole course ready for you, starting from the basics of anesthesia first year to your SS preparation. About the SS, you have neuro, cardiac, pediatric, transplant, and now we also have pain, interventional pain. So, if for everyone looking for a surgical part to anesthesia, you can practice interventional pain. It is OPD based practice, as well as you can do interventions under radiological guidance. So, just like IR, we have interventional pain over here. So, these are all the possibilities that you can do SS in. Again, doing SS is not mandatory in anesthesia. As long as you are trained, you can go and practice it. And if you feel that someone with DM would have a better job profile as compared to me, that would work in corporate hospitals where they will be comparing your CVs and seeing who has a higher degree. Last but not the least, abroad practice. So UK needs anesthetists all the time. You can just go there on an MTI degree, and that is Medical Training Initiative, and then do your FRCA. UAE needs a lot of critical care physicians. So, if you're interested in practicing in UAE or Australia, they need a lot of intensivists. And trust me, I spoke to one of my very good friends just last week, and he said that okay, maybe we can give numbers over here, but he said he earns north of 1 CR in a year just by being a critical care physician. And he has a very good work life balance also in Abu Dhabi. So, of course, going there is easy, and surgical branches practicing abroad is difficult because they want you to be trained in their own country. But in anesthesia, it's nothing like that. You just need your MTI degree in the UK, and the same applies. If you do your FRC in UK, you can use the same degree in UAE or Australia, and you can work. So I think I have sold the branch enough. I don't think there is anything. And but having said that, if you are having doubts about whether you're going to like this branch or no, is it boring for you or no, I would just give one last statement that please go and work in anesthesia for 1 week. Listen to the people who are anesthetists over there, and if you have any doubts, come back and ask me. I'll always be available to answer your doubts and motivate you for this branch. It's a great branch. I did not take it up by choice, but I love it by choice, I can tell you that. And yes, that's all. So over to you, back to you, Dr. Zainab.
Thanks. That was amazing. You sold it and made our job simpler. So I think, Raina ma'am, you can take over. Uh,
There is one
Thank you
question
so
to
much.
Janvi, ma'am. Oh, she left. Oh my God.
left. And I did not waste time. And this, that
No,
is
no, I was
good.
about to ask, like, she told that she didn't take it by choice. I want to ask her what was the first choice.
She can't say that, sir. Now she told it. Now she can't.
So it's a controversial question, but still, I thought I will still sell medicine based on that.
Let's see when Amritsar comes back, we can ask.
So thanks, Dr. Zanab, and hi everyone. I think OBG is not a very favorite branch these days, and we all know the reasons why. But I just want to tell you when I was at your stage and deciding what to take, it was always OBG for me. I remember as an undergraduate, I used to be at the forefront for presenting cases. I would never missed a class. I was in love with the branch, and at that time, I'm talking about uh, this is 2005. So this is like really long back, 20 years back, in fact. And at that point of time, when had to choose a branch, we never really thought so much, like all the pros and cons are a list which we all have ready for you. The money involved, or what my future or what lies ahead, or work-life balance. I never thought any of that. All I thought was I like this branch and this is what I want to do. And that I believe, I mean, should be at the foremost when you're deciding a branch. I think for most of you, it will come from within. You have gone through your internship, you've done your clinicals, you know, you in the back of your mind, most of you would know that you have a sort of affection towards a certain branch, and the reasons, of course, you would know them best. For me, it was OBG, but now I'm very happy though that there's a lot of thought that goes into taking or choosing a branch now, and it's very important also that we need to know um, a bit about everything so we make an informed decision, and that's very right. So I'll just list down, most of you know this, but from experience, pros. So this is a favorite picture of mine. This is just a few years back during the pandemic. Both these babies were born to COVID mothers. These were in isolation. And this is just a very happy picture, I feel. So we were, where I was working in Faridabad, we were the first dedicated COVID hospital to start, and we were at the forefront, right at that time. So it was a happy moment amongst all the sadness that we were seeing. So this is just a picture which I like showing that OBG is an everyday of mine. When I deliver a baby, when I show a baby, when I introduce the baby to the family, for me, every time I do it, every single time, it brings me happiness. And that is why I enjoy this branch so much. So apart from that happy wala feeling, it's a good mix of medicine and surgery. We all know this, as Pur sir mentioned, ortho and gynae. You can do just medicine. If you want to choose the medical part, that's fine. Otherwise, the surgical part. Also, very importantly, I feel there is, compared to other branches like medicine, maybe things like oncology, even pediatrics. I feel you see a lot less mortality and morbidity. Yes, you do see, and when you do see mortality happening in obstetrics, it's actually quite sad, but it's much lesser. There are more happier moments than sad ones, in simple terms. Also, you can survive. It's an end branch in itself. You can survive easily. You don't have to super specialize. Although, to make life easier, many doctors are specializing further. So there's a lot of endoscopy, and there's a lot of infertility IVF clinics, and a lot of fetal medicine, and that includes a lot of radiology also. So your job becomes limited. It becomes a 9 to 4, 9 to 5 job, but you can survive without that. You'll always have patients. If you just set up an OPD, a gyne obs and gyne OPD, you'll always have patients. It's something which a super specialist is not really required. It's just required if you, of course, have an interest, or to balance out your work life balance. And as I said, if you choose IVF, if you choose fetal medicine, then you are set. You have no emergencies and you're quite happy. Also, as I said, you can work up in all setups, all places, tier 1, tier 2, tier 3. It's your choice. Obs and gynae is always going to be there. As a general obstetrician gynecologist, you'll always have work. So these are the list of pros. The cons, which are the main issues with obs and gynae, is the stress. And because of the stress comes a word called toxicity, which is like, I think, OBGYN and toxicity go together. Thankfully, in my journey, I have never had to encounter the so-called toxicity. So I consider myself lucky, but unfortunately, toxicity usually goes along with OBG, and the reason behind that is the stress. So yes, it's a stressful branch. Although there are a lot of happy moments, the end moment is happy. To reach that end moment, you have to undergo a lot of stress. The other part is the income. So the money, as surgical branches all have it, the money is there, but to reach that there, it takes time. It takes time, it takes patience. You don't immediately start earning. Again, as everyone has mentioned, you have lesser earnings in the corporate setup, but if you have your own nursing home, your own practice, the sky's the limit. I mean, I have friends who are earning probably enough to retire at my age. But then I prefer working in the corporate setup because I have a whole team with me, and I have that the stress reduces. So when you have a team around you, you have a lot of people working with you, your stress levels reduce. And I don't like leading a stressful lifestyle. I want to manage my stress better. But those working in the private sector, yes, the stress is definitely there. Long working hours, again, this can be made better, but again, the initial few years, and this I feel is for any branch, whether you take up medicine, radiology, pediatrics, surgery. Yeah, the initial few years as a postgraduate, as a senior resident, will be tough. In obs and gynae, yes, it's going to be a little tougher, but then as you grow up the ladder, as you grow higher in the ranks, the working hours can be reduced. As I said, I have a team working under me right now. I have 2, 3 patients in labor, but I know things are being managed because they will call me only when the patient is fully dilated. That too, if the patient is sort of the one who wants me for delivery. So I know my work is being managed and I can afford to be here with you. So, but this takes time. So I told you, I did my PG I ended in 2009, 2006, 2009 is when I did my PG. So it took me 16 years to reach that stage where I can now relax. Saturation is not a concern unless you are wanting to work in a tier 1 city and you don't have an extra edge over other people. So then if you want to work in a metro, if you want to work in Delhi, you have to have an extra edge. You have to do fellowships, which might be costly. You have to have a niche, or you have to super specialize in a certain area if you want to work. But in tier 2, tier 3 cities, usually saturation is not a problem. You'll always have work, as I mentioned. So this is about OBG. One thing I want to mention, because a lot of you are asking, is work-life balance. How do you manage it? So work-life balance, as I said, is up to you. For me, it is difficult, but I'm also a workaholic. I love working, so I'm busy 9 to 5 at the hospital. Then I teach, as you all know. I have 2 kids. I have the family. I have the home to manage. I have a pet dog also. So it is difficult, but I have a lot of support system. My parents, my in-laws, my husband, everybody is there to support. And so if you enjoy what you're doing, I don't see it as a stress. I feel it's just part of what I like doing, and I enjoy what I'm doing. I have no regrets whatsoever. So as long as I'm happy, I don't see it as a problem. So that's what I said right in the beginning. If this is your passion, if you like this subject, do take it up. It is a wonderful branch. So I think that's it from my side, Dr. Zainab.
I have 2 questions, madam.
Yeah, sure. Tell me.
One is with regards to IVF.
Yeah.
Everyone is chasing IVF now.
Yes.
So what's your take on it? Second is like everyone is chasing MRCOG as well.
Yeah. Okay.
So is it really required?
Yeah. So with IVF, as I said, India is a country with a huge population. So jahan pe you have as many number of deliveries, you'll also have as many number of infertile patients. So it's not saturated per se. The good thing about IVF is it's a very technologically advanced field. So a lot of technological advancements are happening in IVF, and if you are if you are following the trend, and if you know what's happening with respect to technology, you'll always have an extra edge. So you have to, yes, you have to get above the others, you have to work harder, you have to add to your equipment and training. But I would not say it is saturated as of now. In fact, it's a good branch. It's a 9 to 5 branch. Why I never took up, I got FNB in reproductive medicine at Trishur Craft Hospital. I never took it up because it always scared me that I felt there's a lot of sad news again involved in you, because I had a professor of mine who, when the result was positive in the IVF, he would be like the person to break the news. But when it was a negative HCG, he would send the juniors or one of us to break the result. So and the way you, then the patient would be very sad and upset. I would not like it. So isliye I stepped back. I didn't take up the seat, but that was but IVF is still, I would say, very much in demand and a very good subject to follow. The second question, MRCOG. MRCOG is something which everybody is doing, is at least trying to, just gives you an added degree. It is not recognized in India. It doesn't give, it just adds on to your degree. If you plan to stay in India, do it fine, don't do it fine. But if you plan to grow abroad, it gives you an extra edge, especially if you're going to the Middle East, if you're going to Singapore, and of course, if you're going to the UK and some other European countries, MRCOG would give you, of course, an extra benefit because it's an internationally recognized degree. But if you plan to stay in India itself, it's not going to give you an extra edge other than the charm of an extra degree.
Yes, ma'am. Thank you so much. I mean, because most of my residents, even like I'm seeing a lot of OBG residents have been chasing MRCOG like anything. I tell the same thing. It's not a mandate that you have to do it because it's very
Yeah.
attractive for them.
Yeah.
Thanks, ma'am. I also have a follow-up question. You know, how
Yeah.
you said you were always very passionate about taking OBGY. That's how people are, you know. If you want OBG, you just know, you have no doubts. That's why, you know, in the chat, there are no doubts about asking if it's a good branch because they are already sure they're gonna take it. But
Yeah.
you know how a lot of branches we take up because, you know, maybe I might just like it. Do you think there's an arranged marriage kind of a situation possible with OBG, or you either love it or you hate it and there's no in between?
So I know there's a lot of in between. There's some people who just hate it. Of course, it's not for them. But those people who are confused, I suggest you try it out, because I mean, if you have it in you, I mean, if you're willing to just take that added stress and probably a longer working schedule than the others, it is a very good branch because you can limit your practice. You can decide only to do endoscopy. You can do only decide only to do fetal medicine. You can decide only to do minor procedures. So I have a friend who calls me for surgeries. She will be like, she'll recruit her patients and call me for. Many people do that. In fact, one of my professors in medical college, so excellent teacher, lovely person. She was unit head. But OT mein she would never come. She would tell her junior consultants that you go. She would just hate surgeries. So you can limit yourself accordingly, and you should try it out. It's not something which, if you don't love and you have no hate for it, it can easily be. You can easily adjust. I don't think there's an issue there.
Right, ma'am. Thank you so much for that. I think Dilip sir can take over. I think everybody is just waiting for you to start. And, there are so many questions. I think one is DNB versus MD.
Yes,
where-
ma'am. I do have something. So I'm going to discuss everything in the form of pros, cons, the needs,
And sir, please take over.
the myths, and the questions. I think the common questions will be whether girls can take up MD internal medicine or not, whether super specialty is mandatory or not, and whether they have to do MD versus DNB. So these are the common questions. So first I'll start with the pros. So you tend to have lots of options when you take medicine. So my professor, when I started with medicine, he used to say the same thing. I mean, it's not about boasting, but in the past it used to be like that. So it's either medicine or surgery or others. That's it. So nothing more than that. These two are the parent branches apparently, and you have to choose one of them, obviously. And I need not sell medicine because anyway it will be sold no matter what, whether you like it or you don't like it, it will be sold. And everyone, I mean people who are destined to take it are going to take it. I always say that it's not you choosing the branch, it's the branch that chooses you when it comes to medicine. So you have to love the branch, so otherwise the branch is not going to choose you. So because there are going to be a lot of hardships in between, difficulties in between, but you have to go through, very important. So first, as I said, the first pro is going to be lots and lots of options. If you want to work in corporate, you can work in corporate. You want to work in institution, you can work in institution. And if you want to start a private practice, you can start a private practice, and you have a scope for starting a very small clinic as well. With other branches don't offer that flexibility, isn't it? So you cannot be a surgeon and start a small hospital that easily. You need a team, you need an anesthetist, you need everyone. So you cannot be a radiologist and just start a small clinic outside. So it's not possible. You cannot be a obs-gynae and start a small clinic. So, but this is something that's going to definitely offer flexibility. You can be completely independent of others. There's no team that's required, so you are the boss here, and with just a few set of referral people, it's going to be just your game all the way. Second is flexibility. As I said, like it's a very flexible branch. So people keep on asking whether super specialty is required or not. So it's up to you. So as of now, I would say it's required. But again, even super specialization is kind of saturated, I would say, because once take it in this way, in a positive manner. So if you want to become a super specialist, your options become very limited. You get narrowed down to a first tier or a second tier city. You cannot go to other places. So, but if you're just an MD internist or internal medicine, you can just go to the remote peripheries also and you can start practicing. It's not a big deal at all. And you can do a much better practice than an MBBS GP, right? So you'll have much better knowledge, much better exposure. So you'll be doing well. So it gives you a great deal of flexibility. It offers you a lot of options and you can see everything literally. So that's a good thing about this branch. You can communicate with the surgeons, you can communicate with obs-gynae, you can communicate with pediatricians, you can communicate with endocrinologists, you can communicate with onco, whatnot. Everyone. So everyone is going to be your friend and everyone refers cases to you. So that's another pro about this field. And like last 1 week, it's been very busy. So of course, in my hospital, like the transplant surgeons are the ones who are going through the transplants. But fortunate enough, in the last 1 week, I've seen 3 kidney transplants, 2 liver transplants, 1 heart and lung transplant, and 3 LVADs. So all these cases, I'm the guy who gave the opinions. So the referrals, the cross referrals, and all those things. I'm not saying like I'm the primary caregiver of primarily managing them, but at least I got to know. If you're working in a big hospital, you will get to know about all these things. You might be a jack of all trades. You know a lot of things. Like you can like advise people about all these things. And as I said, you're not dependent on anyone at all. So you're on your own. So that also brings you another great deal of independence that even if you do not have much time to learn in your post graduation, you can still do it after your post graduation. That's a big thing about medicine. With regards to surgery, maybe if you miss the bus during a residency or maybe during a researchship, it's very difficult after that. So once you're crossing your 35, 30, so it becomes really difficult to get the skills done. So or have to put an extra effort to learn all those things because it's skill based. But medicine is more of knowledge based and communication based. So it's better. I mean, even if you miss the bus in the first 1 or 2 years, it's still you do have time. You can still get those things later on because the more knowledge you get, the more experience you get, the more you're going to better at it, get better at it. And lastly, you're going to have a right mix of consults and interventions. You're not going to do extraordinary interventions, but there is still a possibility of doing a lot of interventions. Like for example, I do a lot of interventions. I do point of care ultrasound to all of my patients in the OPD, I mean, majority of the patients in the OPD, and almost all the patients in the wards, and I charge for that separately. I do a lot of procedures like bone marrow aspiration. I do lumbar punctures. I do central venous catheters. I do A lines. I do the PIC lines. Most of the difficult cannulations, I tend to do it. So you can do a lot of interventions. I mean, these are basic level interventions. I'm not saying very advanced, but still you can do it. It's not like it has a right mix of those. So these are the pros I would like to say. So what are going to be the cons? Like Apusa said in the beginning, the learning never ends. So you have to keep learning. So that's the most important thing. And you have to keep getting updated. So, and this field, yes, like any other field, like this is also a field where you see a lot of internists because there are a lot of seats and all of them are going to get filled. And of course, like you have a lot of competition outside. So if you want to really stand out of the competition, you have to be the best guy out there. So then only you can stand out and then only you'll be earning more. So income in internal medicine is directly proportional to your knowledge and skill. And so what are the needs? I mean, for example, if they ask you like to gain so much, to earn so much of money, or if you want to be a best guy out there, so what are the needs? First, when it comes to internist, the communication is very, very important. So how you have to present yourself to the people and how you have to talk to the people so that it doesn't only convince them, because in the era of like chat gpt and era of Google, so how you are going to stand out, how are you going to convince a patient, that's very, very important. So communication skills. So my professor always used to say, You can be either optimistic or diplomatic, but not pessimistic always. Because the moment you start with pessimism to someone, they don't come back to you. So, how to get that art of optimism and diplomatism like over the period of time? So, with a touch of like maybe sometimes if a patient is in a terminal ill patient, so how do you explain that to that? So, all these communication skills matter a lot. So, that you have to learn first during your residency. Second, with the communication comes with the art of empathy and sympathy. So, this is one field where AI is not going to take over, at least at this point of time. That is because we are humans and you understand others' pain and emotions. So a lot of people are coming with a lot of pain waiting for you for hours together, and how you're going to sympathize and empathize on them. That's so important. This is one field. The medical field and the surgical field allows you to understand others' emotions and to reciprocate in return. So that's one of the important need of this field. And I would say knowledge, of course, the third thing, very, very important pillar. If you're not knowledgeable, of course, you will get exposed very fast. In this fast growing era, like you're not going to last longer. People will understand at some point of time that you are not a knowledgeable guy, and that is going to definitely put a dent on your career. And exposure, of course, that's why we talk about the good colleges, the exposure. So to bridge that exposure, I know not all people see. I always say that rank one is only one rank. Unfortunately, you don't have many rank ones. Similarly, like not everyone is going to end up in a good institute. So that's the reason that exposure part we at conceptual medicine are trying to take care of. So we're trying to teach that so that that gap is bridged, like Apu sir keeps saying. So we wanted to create a level playing ground. And finally, last but not the least, the skills. I mean, why I kept the skill at the last is because skills, I would say, like Amritsar would agree, maybe that's the first thing for a surgeon. But when it comes to an internist, it comes the last because, like, you may not be that skilled, but still you can succeed. So, with the art of communication, empathy, sympathy, knowledge, and exposure, you might be still able to manage. So, coming to the famous myths, like people think like medicine is just empirical, 100% not. So, you can come and sit in my OPD. You can clearly understand that it's 100% not empirical at all. We see patients, we analyze them, we create an algorithm, we create a differential diagnosis based on that. So sometimes like it even takes 3-4 minutes for me to decide on whether to give a drug or not. We tend to ask so many questions. It's not at all empirical. If you're going to try and be empirical, this field I think like it's not going to give you much rewards. And second, it is not a conglomeration of basic sciences because people who are attracted to medicine always think like it's just a conglomeration of basic sciences like pathology, pharmacology, microbiology, and whatsoever. So it's not, it's completely different. It's clinical. So just because you know how to put the gear independently or how to press the brake independently, you cannot drive a car. So that's what I would say. So the basic sciences alone is not going to help you because undergraduate level, yes, you do something with all these basic sciences, you can do something with medicine. But when it comes to the field of like practicing medicine, I don't think it's going to work. So if you are in the illusion of thinking that if I cover all this, I will cover medicine, please don't come here. So last but not least, another myth is always you have to do super specialty. At least at this point of time, it's okay if even if you don't do super specialty, it's fine. You can still do well, provided you are practicing in the place where your uh, career is going to progress. So maybe it could be in a corporate hospital. For example, I work in like I don't want to name right now. So I work in a couple of hospitals where they see me as an indispensable person at this point of time. So that comes with another quote. So I mean, this is one of my favorite quotes ever. So you have to be humble enough to know that you are not indispensable. At the same time, you should be confident enough to know that it takes 4 people to replace you. So that's what favorite quotes. So you're always replaceable. So but still you should be confident enough. You have to develop that aura so that people feel like it's not easy to replace them. That's what is important. So that's what I've tried and achieved in my career so far. So like hopefully it works. And lastly, the questions. So there are 4 5 questions. Yes, MD versus DNB. According to me, there is no big difference as far as medicine is concerned. People talk about exposure. I mean, it depends on the institute again. If you're in a good DNB institute, you're going to get exposed to the same amount. So most of the time, it's better. See, it's not someone who's going to like hold your hands and you're going to make you write the prescription. That's not going to work here. So you have to observe the good consultants. You have to see like what they're doing. Like sometimes you have to question them. So why you're doing that? Then you learn accordingly. So that's how you learn. It's not like nobody's going to come and teach you like this is how you write, this is the dot, this is the comma. Nobody's going to do that. So second, so my final take home message is like DNB is as good as MD. So there's no doubt about that. And whether girls can take this field or not because they feel like the work-life balance will go for a toss, I would say that again, like a lot of people have said before, it's you are the boss who's going to draw the line. So there's no end for greed. So if you want more money, you're going to work more. If you're going to, I mean, if you're satisfied with something, yes, you can wind up your job at 4 o'clock. You need not work after that. It's up to you. So there's no question of work-life balance. So you can work in an institute and say like, I'm not going to work beyond 4. So when you are free after 4 or 5, it's your decision to put a private practice in the evening at 6 o'clock or 7 o'clock and work till night 11 o'clock. So it's up to you. So it depends on how much income you need and how much, if you earn, you're going to get satisfied. So that's number two. Third, whether too easy to start a setup on your own or not, it's not actually. So there are a lot of corporation guidelines and rules that are have to be followed, and a lot of norms has to be fulfilled before starting a setup on your own. But yes, it is possible, and especially if you choose the right place, a strategic place, yes, starting a setup is a boon, and you can earn unimaginable amount of money that I've seen a lot of people earning in this field just being. I mean, when it comes to corporate practice, also nobody sees what degrees you have, whether you have an MD or a DNB or a diploma, it doesn't really matter. What matters is the revenue that you're able to generate. That's the hard truth. The more the revenue you generate, obviously, like you will be indispensable to the hospital. So it is more of a strategical thing rather than like just to talk it out bluntly. Lastly, the MRCPs. So whether MRCP is required or not, like I agree with Raina ma'am completely. You may do it or you may not do it. It's totally up to you. My take is like it's just an attractive degree because people, I mean, even I did the MRCP degree just because of an attraction. Later on, I came to know that it's not going to be of any use. For that matters, in my hospital, I've been respected for the fact that I'm knowledgeable. I've been respected for the fact that I bring in so many patients. I'm respected for the fact that I generate a lot of revenue and I have a lot of international patients as well. So that is the sort of thing that creates a respect. So nobody knows even my degree sometimes. So it's just an attractive degree. That's it. If you want to do it, yes, definitely you can do it. If you want to learn something extra, or if you want to settle abroad, yes, it's a good thing. You can do it. Otherwise, like it's not a mandate that you have to do it. And finally, I want to settle with two things that there is a lot of scope for good internists still. So it's not a field that is saturated completely. So the scope depends on the person, like Gogabai says always. And lastly, I mean, in internist, I mean, internal medicine, we say a golden rule. I always say this to my residents as well. The only time that you'll be wrong is when you're sure you're right. That's very, very important. So not, I mean, you have never, you have to be always like thinking laterally. So whether this is right or not, you have to always question yourself. The more you question yourself, you're going to get better at it. And with this, I'm going to hand over the baton to Dr. Amrit Nasta next, ma'am. Sir?
Sir, before sir starts, there are a few questions in the chat. I think your opinion on family medicine, geriatric medicine, and ID. If there's a direct entry, particularly to INI, what are your opinions on these branches? Also, respi.
Yes, the problem with pulmonary medicine in India right now is it does still have a scope, but one big problem that you're going to face is a lot of internists are going to take over pulmonary medicine. For example, I get a lot of tuberculosis, I never refer to pulmonary medicine. Honest truth. I get a lot of LRTs and community acquired pneumonias, I don't really refer to pulmonary medicines. So I have a lot of COPD patients, I don't refer to pulmonary medicine. So most of the core cases of pulmonary medicine are handled well by internists itself, the MD internal medicine, and I mean most of the super specialists. For example, a cardiologist knows how to treat a COPD. So that's the issue with pulmonary medicine. So you might not get good number of case referrals. So unless and until you have a good, really strong support system in a corporate hospital, it's really difficult to get cases. And right now in India, you have to like consider pulmonary medicine as a second choice after internal medicine. That's what my take would be. In case if you do not get it, then fine, as an alternate, but not a primary branch if you get internal medicine. And second thing, you asked about geriatric medicine. Geriatric medicine, again, the scope is very limited right now. So, because of the fact that people are not aware right now, and again, the support system is not good in the country right now because not many doctors are aware about the field and not many doctors wanted to really give up their patients. So maybe if you're working in an institution, it still works, yes, because obviously in institutional setup, it's very different. So they wanted to give away patients to other departments. But when a corporate hospital, they don't really want to give up. For example, I have a lot of 70-year-old plus. So I treat myself. So I don't really refer to geriatric medicine because we are always afraid of losing our cases, losing our patient set. So that is one thing that you have to consider, because in a corporate hospital, it's always the revenue you generate and the numbers you see. That's very important. So in institution, yes, fine, again. But if you're living only in institution, your income is going to be less. You have to expand your practice. Third, about family medicine, the biggest advantage of family medicine is just like a sister of internal medicine. So you tend to see all the cases, but again, the scope is not very much like internal medicine. It's very restricted. You'll not be able to do that much of super specializations. So it's like an end specialty. You have to settle with that, and you have to be more of a healthcare kind of a person. That you have to know the preventive aspects of it, and you have to deal with the patients in their home. So sometimes most of the family physicians go to the home visits. So your things will be restricted to that. If you are going to love that kind, so if you want to directly interact the patients in home, you're going to be like a relative to them, then yes, the name itself says family medicine is good for you.
Perfect. So basically, patient acquisition is one of the major problems with
Exactly.
branches, and if that can be sorted for you in terms of any channel, then you go for it.
And ID, I think, like you have talked about, asked about infectious diseases. ID as a branch, again, the problem is the same thing. It comes to the same square. It's an egg and chicken story. We don't get the patient acquisition. It's like, who's going to refer the patient to you? So everything is ID. I treat HIV. I treat tuberculosis. I treat all the infections. I mean, see, people do get, we still see in the critical care units, right? Unless until patient is having an infection that is resistant to all the antibiotics, we don't call an ID. So till the time the critical care physician or the internists are trying to treat.
Yeah.
So that's again is going to be the problem of patient acquisition. That's the issue with the ID. So it's not like other countries right now. The dynamics in India are very different. So I'm talking about the real world scenario in India. So the dynamics are very different. Still, that referral thing is like very difficult to get, because you have to really be good enough to get referrals from other doctors.
Yeah. So I think the moral of the story is like be like Dilip sir, and you don't need to do anything else. You are gonna eat up jobs of 4 other specialities. So that is what is the moral of the story, that you be good at your job and take up anything, and if you're good at your job and you have the skills of communication, I think those are the two big ones. I think Amrit sir can take over, or Anand sir, whoever wants to go first. Anand sir also has been waiting for a long time, so anybody.
Anand sir, you want to go first or may I? Uh, I will
As
allow.
you say, आप कर लीजिए, कोई बात नहीं, no problem.
Are you sure?
It's okay, no, आप कर लीजिए.
Okay.
It's
So
okay, says volume, sir. Okay, Amrit sir, go.
whenever I will talk about Dilip sir before he goes. Whenever I meet him, or like whenever I listen to him, I feel like we are like brothers. There are so many thoughts of mine which echo in his voice, the things that he says. Like half my job has been done by him. Even though he spoke of medicine, there are so many overlapping things. I was like, okay, he's made my life so much easier. Like there are not so many things that I need to clarify now. So thank you, Dilip sir. And listening to you always makes me feel I'm not the only one who thinks that way. It is so much reassuring. So, Zainab ma'am, before I begin, are there any questions that you would want me to address?
Sir, basically, who should take up surgery? More importantly, who should not take up surgery, I think would be a question you can answer.
Okay. So I have a few points which are normally what students normally ask me, I'm getting this rank. Obviously, surgery is not the preferred branches in today's day and age, needless to say. And I don't want to promote it and I don't want to dissuade you, but I'll just give you a reality check similar to what Dilip sir said about some of the common concerns. First concern everybody asks is work-life balance. You know that I will take up surgery, my life will be hell. Is it so? I feel that is up to you. So if you want to make a lot of money, yes, your work-life balance can be skewed, but you should understand one thing. It is only in the initial years of your practice. Now you will start your practice after your MS or maybe MCH, and it'll take you a few years to settle down. But once that period is done, you can hire juniors who will do the running around work. So your job, as I see many senior consultants do, they sit in the OPD for a few hours, they acquire the patients, and because they are senior, patients listen to them. And then their OT job is only at the key steps. So they are able to do more work and more refined work versus doing the donkey work. Yes, there is donkey work, but that will reduce over time. This is what a lot of young surgeons don't know because they talk to junior residents, and junior residents are in a mess. So they will always say, no surgery, your life will be hell. Residency is tough. Not just residency, first few years of practice are tough, but over time, you can get it to that stage where you are not working 12 hours a day, 7 days a week. It can be cut short if you have a good team and if you have a good junior, who can do the running around for you. So that will bring quality to your work. So is work-life balance a problem? Definitely in the first 8 to 10 years. After that, if you play smart, then you can have a good work-life balance, because we see so many surgeons going for trips and conferences all the time. How are they leaving their work? It's because they know there is someone at the back. And I was that fallback guy for a long time in the early years of my practice. I was working with a very senior surgeon who taught me bariatric surgery, and I used to do all the donkey work. So I know what I was doing for him. Obviously, someone can do for me if I find the right person. Second thing is MCH a must? Honestly, it is, especially if you are settling in a big city. I didn't do MCH, which I regret now in hindsight. But I am in a branch where MCH is not that required. Like there are very few branches left in surgery which you can do without MCH. Like I'm doing bariatric surgery. There are very few. Maybe endovascular treatments. There are few, three, four branches where as of now MCH is not a must. But apart from that, big city practice, you must do MCH. So you have to add that to your calculation of settling down. Will I settle down late in life? Another common question. What is really settling down? Do doctors ever really settle down per se? We are so hungry. We just want to make more and more. And when, in surgery, when you'll reach 40 years of age, that's when you'll start raking the moolah. You'll start making money later on. So why would you want to settle? You would want to make more, you want to maximize. So yes, you will start late. But when you're maximizing, you will not be like, okay, now let's relax. You would want to continue. So you make more money in the latter part, but you can make a lot of money if you want to. Another question that is asked is, do I have to be skilled from the start? Absolutely no. Okay, there is no skill that has to be there. It will take years and years and years of practice to develop the skill. And even if you miss out on something, now there is a lot of technology. Again, young surgeons don't know this, or people who are aspiring. Surgeon's life has become so easy with technology. I am sure Raina ma'am will also agree. We have robotic surgery. We have instead of using cautery, we have different energy devices. They make surgeon's life so easy that you are no different than a super duper senior surgeon with the technology. So with robotic, you are just as good as any other surgeon with 20 years of experience. It reaches that stage. The learning curves are not so long. So you don't have to be skilled from the start. And MSDNB, the lips are answered for medicine. It holds the good for surgery. It holds the same for surgery. Yes, little less exposure, no doubt about it. But you can compensate it, especially if you are going to do MCH. So whatever you missed out, you cover up, because in MCH it will be more specific. So when you are doing MCH, whatever you didn't learn, it's okay. You will learn in that period. Another common question asked is, I got a rank where I'm getting a 6-year course, like a 6-year neurosurgery or 6-year cardiothoracic surgery. Should I go for that versus go the MS and MCH way? I would say that's a very dangerous choice. It's like getting married, once you are married, you are committed. So if you go for a 6-year course and after a couple of years, if you realize, no, this is not where I want to be, you're stuck. And then there is no going back. If you do general surgery, get a little exposure, then it will make more sense to choose. Which is why 6-year courses, unfortunately, are easier to get into because people are aware of this. So even at a poorer rank, you will get a 6-year course. But there is a reason for that. It's not really lucrative. It has a trap. So I would not recommend going for that. And the last thing is, are surgical branches saturated? Honestly, no. Uh, I have not seen a single surgeon, at least in Mumbai, who does not have a good practice, whether he's a general surgeon or a specialist. You just have to be available. If you are available, you will get work. And if you are available, you will become good over time with practice. Only thing is, will you get quality work or not? That depends on your skill, on your communication, convincing your patients. Like the branch that I am in, bariatric surgery, patients don't come to me, and it's not very easy to convince them to get a surgery for obesity. That skill has to be developed. But for other surgical work like hernia, onco surgery, there you don't need so much convincing skill. You just need a good PR. If you have good PR, you will get good patient load and you will get good work. So these are some of the things you should be aware of. And normally, whenever students ask me that I want a branch where I will get a lot of money and work-life balance, so I ask them to kind of put things in order. Like there are 4 or 5 things you should consider before choosing a branch on your preference. Like, do you want job satisfaction? That a clinical branch will give you very well. So, general surgical branch, orthopedic, OBG, general medicine, they will give you immense job satisfaction. Money, of course, you will get, but it will come a little later, and there can be enormous monetary potential in surgical branches. Time for self will also come later when you have a set up practice and you have people to do the running around for you. Of course, these branches are going to have glory. So you will feel that, okay, you're going for conferences. People in your society will know, okay, you are a surgeon or an obstetrician or an internal medicine. So that glory, that respect comes, which will be a little more, definitely. And the last, very important, is effort to reward. The time that I will spend in the OT will yield me a good amount of response or reward compared to sitting in OPD for the whole day. But I have to get that patient in the OT. If I sit in OPD whole day and the patient does not get converted, then it's a wasted exercise. So effort to reward is a big game changer that you should consider when you are going for a surgical branch. Who should not take surgery? If you hate surgery, then you can choose to not take surgery. Like if you hate the sight of OT and you don't want to be involved in pre-op, post-op, then it's okay. But if you're neutral, then you can take up surgery. So those are my 2 words of wisdom.
Dr.
And
Amit, I have a doubt. Like compared to obs and gynae, which is also a surgical branch, is surgery more which would you is the work-life balance better with surgery? Do you have more emergencies? How is the night emergency scene? Because I get this asked a lot. कि gynae में nights में how many nights do you go to hospital? What about surgery?
so in branches like bariatric surgery, urology, there is no emergency. But if you are doing onco surgery, plastic surgery, there may be on and off. Honestly, in private practice, over time, emergencies in most surgical branches reduce, at least the super specialty branches. General surgery emergencies will always be there. So, lap appendix and cholecystitis, perforations will always be there. So, your aim should be that over time you reach a spot where you don't have to go for these emergencies, your practice becomes more and more elective.
Right, right.
So I think I'll now allow Dr. Anand sir to take over. Thank you, sir, for allowing me. Over to you.
So much, sir. That's great. Good evening and regards. My name is Dr. Anand. I'll be speaking. Number one, P for pediatrics, P for passion. You need to have a lot of passion, but the problem is P for passion, P for patience. Like the way from the last 1 hour, my dog is waiting and waiting that when this class will get over and he'll go. You need to have a lot of positive patience. My son also have. Everyone is waiting for dinner, but positivity and patience is there in pediatrics, because in pediatrics you don't treat the child, you treat the family, you treat the mother. Counseling plays a very important role. So number one, first question, girl or a boy who should take pediatrics? Anyone can take pediatrics. It is not gender biased. Second question, will AI will what you called cover pediatrics? So basically AI will not do anything, because most importantly in pediatrics you need to counsel the family, and AI don't have a role in that. Third question, work life balance. Work life balance, it all depends on you. You can have a very wonderful work life balance. If you want to earn a lot of money, it's nice. After 9 to 4 job, you can have your evening private clinic, or weekend you can go out peripheries for postings. But otherwise work life balance is pretty easy in pediatrics. Next, very important, what are the negative points? Positivity to everyone knows, but what are the negative points of being a pediatrician? Number one, of course, patient counseling sessions are very important. You don't treat the child, you treat the family. Mother has a whole story to tell you. Doctor, मैंने ऐसे किया, मैंने वैसे किया. He got a fever, he got a cough. I grinded this thing. He vomited 3 times. Then you know what happened. So she has a whole story to tell you. All you have to do is just listen to her like this, like a story, and she just counsel her basically. And secondly, medical legal cases, of course, are there in medicine also. It is there in pediatrics also. So you should know how to counsel. Documentation is very tight, has to be there in pediatrics. And as far as the super specialty is concerned, it's not mandatory to do a super specialty in pediatrics. You can very well do MD Peds and earn really pretty nice. NICU, like the best part about pediatrics is like for the NICU, neonatal intensive care units, you have 4 or 5 diagnoses, and the whole story revolves around it. So you can earn pretty good amount of money. So it's not that pediatrics is a boring branch, but the only thing it is, you need a lot of patience, because they are really newborn babies. Like this devil is there sitting next to me, so you need to take care of them. So you need to have a very positive attitude, and that's the whole story. And last but not the least, I would rather say that don't run behind money. Paisa kisme zyada hai, paisa kisme zyada hai. That's a wrong question. Where is my passion? Ask yourself, and your first thought is the final thought. So don't run behind money. Don't run behind wanting to get rich. Just be good at your job. Feel what are you good at, and everything will make sense by the end of the journey. That's all about pediatrics. Thank you so much, everyone. Ma'am, I think we should wind up.
Yeah,
Is that
Dr. Anand, and you're the perfect example of work-life balance, Abhi. A class with your son. The same thing
yeah?
with my kids also running around, but we learn to manage. If you love the
Yeah.
subject, we learn to manage.
Very true, because patience is very important. From 1 hour, my dog is waiting, and very, very patiently, you have to be very kind and very soft and kind of feel chill out in things. That's what. So, thank you so much, ma'am. Thank you, everyone.
Thank you,
Yes.
thank you, thank you, everyone.
Yes. Thank you. Yeah. Bye bye.
Thank you, guys. Thank you so much. Thank you,
Thanks,
ma'am.
thanks. Good night. I hope everyone learn from this session. If you have any doubts, you can write them on the chat box. We will get back to you. Thank you.
Thank you, guys. Thank you.